Now it is my proud privilege to invite our guest faculty, Dr. Deepak Edward from USA, to speak on neuroprotection in glaucoma. Welcome, sir.
Good morning, and thank you for the invitation to speak at this symposium. My topic today is talking about neuroprotection and where we are in 2024. So our learning objectives today are to understand the fundamental principles of neuroprotection, why is it important, a brief thing about history, and what, if any, options are available today in our way we treat patients with glaucoma. So just going back to some of the basics about the retinal ganglion cell, which is the cell that dies in glaucoma at the back of the eye, is that these cells die by a process known as apoptosis, or programmed cell death. The cells die without inflammation, without necrosis, and they become pycnotic like this. And if you do special labeling with an antibody called tunnel, and you can detect these cells dying. And how do these cells die? By apoptosis. Of course, the mechanism is somewhat complex. Most of the damage occurs at the lamina cribrosa, affecting the ganglion cell, and where is the damage in glaucoma? And as you will see in the next slide, the mechanisms of apoptosis is complex. You have extracellular matrix changes at the lamina cribrosa, making it more stiff. You have reduced axoplasmic flow, which causes growth factor deprivation in the retinal ganglion cells. We'll talk a little bit both about therapies, giving more growth factors. There are CSF changes that can happen that can affect the optic nerve, and also cytokine and matrix metalloproteinase damages produced by the astrocytes in the optic nerve. So it is quite complex. So if you look at this in a different way, you have an initial insult of increased IOP, again, not in all cases, but in most cases that we're talking about. You have mechanical compression, axoplasmic flow deregulation, all these processes happening, the end result being a dysfunctional and retinal ganglion cell, and somewhat irreversible visual loss. Ganglion cells can recover, especially after you lower intraocular pressure, those that are sick. But if once they die, you have irreversible visual field loss. So why do we talk about neuroprotection? The only way we can right now treat glaucoma, real modifiable factor, is lowering the intraocular pressure by medications, lasers, and surgery, as our former speaker talked about very nicely. But there are limitations of treatment, side effects of treatment, medicines, inadequate IOP control, poor compliance, and the need for ongoing monitoring. And sometimes in patients who have advanced glaucoma, the damage persists despite lowering the IOP. So neuroprotection is really looking at non-IOP related interventions that can prevent or delay glaucoma loss independent of IOP. So I'd like to briefly touch upon this older study using this molecule known as memantine, which was targeting a receptor called the NMDA receptor on a postsynaptic neuron, that is the ganglion cell. And this was the theory of excitotoxicity. So Allergan funded a very large clinical trial, which is probably the most expensive trial in glaucoma history, but the trial failed. And this put back research into neuroprotection in glaucoma by many, many years, because people were very discouraged after the results of this trial. So what's new? Are there any agents on the market? We'll talk a little bit about how you can enhance neurotrophic factors, mitochondrial dysfunction, how that is being addressed, and a few words about the others on the list. So one of the things, this is not something new, but it's kind of old, but a nice paper to realize, looking at brimonidine as a neuroprotectant. And there was this very nicely designed 4-year double-masked randomized multicenter clinical trial using brimonidine and timolol. And the graph kind of summarizes the results, showing the protective effect on the visual field with brimonidine compared to timolol. So there's been some controversy as they say, well, maybe brimonidine is useful, but it also, timolol might be potentially harmful. But animal models kind of support that brimonidine can enhance survival of RGCs independent of IOP. What about neurotrophic factor administration? I previously alluded to the fact that growth factors are no longer present, and that's why these ganglion cells die. So there are two very exciting studies in the last few years looking at, these are phase 1 studies, looking at a short course of topical recombinant human nerve growth factor. There were 16 randomized subjects, and again, being a phase 1 study, they really looked at safety. But the interesting thing in this very small subject group, there was trends in improvement of the Humphrey visual field and RNFL, and a phase 2 trial is being planned and executed. A more exciting study, which was very recently published, again, this is using a little device that contains pigment epithelial cells that produce ciliary neurotrophic growth factor. You implant it into the pars plana, and these cells continue to secrete CTNF. And the primary outcome, of course, being a phase 1, was 18 months of safety, but the implanted eyes did show some increase in RNFL as measured by OCT, and there was some improvement in visual fields, though not statistically significant because of the small numbers, but the untreated eyes actually got worse. So we're waiting for the phase 2 results on this one. What about mitochondrial dysfunction? Again, this is a very busy slide, but here is a slide this is a study that came out of Australia, showing how vitamin B3, when given at very high doses, improved visual function and perimetry in patients. There's 2 large trials going on in the US and in Sweden that started in 2022, and we really won't get results till 2026 to see how this very simple treatment that helps mitochondrial dysfunction help us in neuroprotection through alleviating mitochondrial dysfunction. What about stem cell therapy? So I'm not going to spend much time because there is, you can use mesenchymal stromal cells or human embryonic cells. These have not found to be very effective. The approaches have been, to restore TM function or directly replace retinal ganglion cells. Many studies have been registered at the clinical trials database, but we haven't seen results from this. One also should be aware that there's a series of cases published out of Bascom Palmer showing someone injecting autologous stem cells for AMD, and these eyes underwent terrible visual field loss. What about gene therapy? Again, not very successful. The attempt of gene therapy is really to get more growth factors in using things like brain-derived growth factor, the TRKB receptor, and all neurotrophic factors so that the cells could overexpress them and protect them, but there are no human studies, and even the studies in animals have not been very promising. What about antioxidants? So there are plenty of antioxidants on the market, and the bottom line is clinical evidence of effectiveness is inconclusive. Citicoline is one that has been widely touted, and again, there's very little data to support its benefit. This is available on Amazon in the United States, and it's a very popular drug bought by patients. What about immune modulation? So in the animal model, it seems to be really good that if you can, because there's a role of immunoregulation in death of RGCs, but there are no human trials to date. So what about a summary of what we just said? Despite ongoing effects, the neuroprotection is a challenge because of the complexity of glaucoma. You saw the different mechanisms that are involved. There's individual variations, and the measurement of neuroprotection is also hard, and regulatory hurdles are also difficult. Long-term efficacy is not known, and patient access is kind of limited and costly, but I think there is hope. So thank you very much for this invitation, and thanks for having me here.
Deepak Edward. That was nice, but as we all know, neuroprotection still seems to be a myth. And yes, there is hope at the end of every dark tunnel, so we shall wait and see what